Morning.
Good morning.
Hi.
Good morning.
Morning. Katrina, I thought you had clinicals on Mondays now.
I'm in my car. We start at 8:30.
You are so funny. I was thinking, how weird, because you're always the first one. And then are you skipping clinical for this? How's everyone doing? Getting tired?
Morning, Miss Amanda.
Good morning. We're almost there. We're so close.
I know.
It seems so far, but it's like, I can't even believe we're at the end of endocrine. It's just, wow. It's just, I don't know. For me, it's flown by, hopefully for you in a good way. But I can't believe it's Monday and we have only I always want to say GU, but we're doing GI, right? Yes, GI, which is actually my favorite. So I think I say that about everything though. So I'm a non-reliable source. So we'll just give a couple minutes. I'm anticipating probably a couple less people just because I know that there's been like the last 2 weeks has been pretty rigorous, and a lot has been going on with new clinicals and COVID tests and flu injections and all this stuff going on. And you guys had a big farm test, and you're in the middle of doing my test. So I'm probably only anticipating maybe 15. So we'll give about 3 more minutes just to let people sign in. And then we'll do, today's pretty, I mean, I don't want to say easy, but it's a pretty, I don't like the word easy, but it's a pretty well-known topic, which I really like. And I'm hoping to put some light on some good patient teaching things and really focus on, especially, I've been starting to grade the video. So if you haven't gotten your grade yet, it's not because I haven't been doing it. I mean, there's only so many you can watch in a day because I really want to, pay attention. So watching a 10-minute video can be, that's 10 minutes. So I'm trying to do like 5 a day, and probably tomorrow more once I'm off clinical. So awesome. More people are joining. Beautiful. So I just opened up the chat. So if anyone has anything to say, the chat is open. Perfect. Oh, that's how I want you. Okay. Wow. Yeah. Took me this long to figure it out. Good morning. Thank you, Catherine. Because I like to see all of you, because usually I only see some of you, and now I just, like, there's this little button you press, and now I can see all of you, which is nice. Well, I actually don't see any of you, just Amy. Amy's like the only real face, and she has her blankie like me. It's cold. All of a sudden, like it went like one day it was 90 and then boom, it was like 60, which I love. So, okay, I think we'll get started. Correct me if I'm wrong, but there's, 10 participants. So, as I kind of anticipated. So thank you again for those of you, especially that are in clinical in your car, for coming. I really appreciate that. So just, I believe you're going to see me looking. I have like a new little way I'm doing this since I'm doing so many more classes now online for other schools. Good morning, Jessica. I think that's Jessica. Yeah. Aren't you supposed to be in clinical, Jessica?
Oh, hold on. Sorry, can you hear? I didn't hear ya.
Aren't you supposed to be in clinical?
Oh, no, I don't think so.
Right. Just making sure. I'm like scolding everyone. Okay. Glad to hear. Okay. So, oh, America, I haven't seen you forever. It feels like it anyway. Okay. So just a couple housekeeping things, and now more and more people are adding on. So now we're up to 13. So you're going to see me looking over here just because I have points that I don't want to forget to make. I do have a PowerPoint presentation that I posted on Canvas. So I will be using that today. Today is a little bit of, I guess I'm going to use the word simplistic as far as us understanding diabetes, but of course reviewing is always good, especially since we haven't had as much time in the clinical setting, especially with skilled nursing, but now a lot of us are back in the, I think Empress, I'm at the forum, well, where am I? The forum. So we're getting more exposure to being able to give insulin and deal with that population, which is really good. And of course, Miss Lisa in the lab, I know that you had to do all of the testing. Can everyone hear me? I'm on full, but I feel like I'm not talking very loud. Can you hear me? We're good?
Yes, you're good.
Let me know if, type in, say, talk louder. So housekeeping is, so today is technically the last day of endocrine. So I know, I'm not sure if we probably haven't or may have looked at under the syllabus, it says that I've already started making the schedule for GI. I always give a couple days because we're not really done. I usually consider it done 2 days after because that's when the test is due, is on the 18th. So I'm going to start tomorrow. You'll start to see assignments coming up. Another thing I wanted to mention was ATI. I've been having some a little bit of anxiety, so I did do an announcement. I'm not sure if you saw it. I know you're bombarded with them all the time and emails, but as far as the ATI exam, I do have to give one. I didn't forget I had to give one, but then I just remembered I've actually never given one before. So I'm kind of working with Miss Marcia. So I know that they're given and they're proctored. So just kind of hang tight with me. We're having a meeting today, so I will get you that information so that you know kind of when to schedule. I don't know if I can do, it just seems kind of unfair to do, in my opinion. You must be here at this exact time for 1 hour or whatever. So I don't know, especially with COVID. So I'm going to see what I can do to try to make it a little bit more. Maybe we can offer 2 times. I'm happy to do that. I don't mind. So, and that, again, I do want to make sure I'm going to do a sliding scale. So please try not to stress too much over it. ATI tests are really hard. I mean, even for myself, we use ATI in school. I'm not a fan personally, just because I feel like I teach, but I don't know what the test is going to ask you. So I can't kind of prep you for it. So I will definitely do a scale. I'm not going to give you, if you get a 20, I'm not going to give you a 20 out of 50. So please, just like most instructors, keep that in mind. So hopefully that will lower your anxiety just a little bit. I have to give you a comprehensive test at the very end as well. It's going to be 100 questions. You will have a study review. And if you have seen how I've tested on purpose as repetition, I think everyone's kind of seen that. There will be that as well. So I think you all know what to expect, which I think is nice. The only other thing that I wanted to mention is, I already mentioned I will have the GI schedule up from Tuesday to Thursday. That's when I'm going to be working on it. So you can at least start it if you want to on Tuesday if you've done your test. This class is not going to go till 10:10. I mean, if we really want to, we can, but I mean, I have all my notes and we will go through the PowerPoint. I did adjust it and I deleted, there were like 79 slides and a lot of it was repetition and I just didn't feel it was necessary. Quality over quantity, in my opinion. And then of course, if there's any questions, and you guys did the diabetes concept map. So I just feel like there's so much diabetes stuff going on. I'm just going to kind of slide in those little things that maybe you have forgotten or maybe you haven't thought of or stuff that wasn't really in the book. And on the slides, I'll add stuff in. So that is the housekeeping stuff. Any questions before we get started, just in general about the class, grading, that you're comfortable saying in class to the 17 of us, 18 of us? 17? Oh.
Good morning.
Hi. Hi, Ellie. That's Ellie, right?
Yes.
Hi, good morning. Did you have a question?
No, I don't have it. So
Oh, well, good morning. That was okay. I like it. It's always nice to have a nice good morning. Start the Monday off right. Okay, so let me go ahead and just share my screen with you so we can start with the PowerPoint. The expectations for today are pretty much, I have, like I said, the PowerPoint, I deleted about, I would say, a third of it, just because it was so repetitive if you looked over it. I do have 2 videos. One is just kind of an overview of diabetes type 2. Not that I'm not going to explain it as well, but I do like the way that you'll see why once I'm showing the video. And then also DKA, diabetic ketoacidosis. That's probably, in my opinion, one of the, I hate to say most important, but it's a very, very, very critical thing because it's life-threatening. And diabetes is a really hard disease process to manage. And that's what we hear of a lot. And that can be a life-threatening occurrence. So we want to be able to know the signs, the symptoms, what's going on, and why does it happen? And I found this video, maybe I think it's cool and you don't, but it's actually of a girl. And both the videos are short. One is 7 minutes, one is 8 minutes. And it's basically her telling her story. She's a diabetic type 1. It usually happens in type 1, sometimes in type 2, but usually more prone in type 1, and we'll talk about why. But and she tells her story about what happened, and it's such a good opportunity to show you as the nurse why the patient teaching is so important. I'll just kind of, I'm horrible to watch movies with, so I'm going to spoil it, but why she went into DKA, she couldn't figure it out. I mean, everything was on point. She had an insulin pump, which we'll talk just briefly about, and if there's any questions, because those are becoming more and more popular, because who wants to stick themselves every day and, be off. Oh, yay, people are coming that are usually not here. Hi, Julie. Good morning.
Hi, Miss Amanda. Good morning.
So cool, because like the clinical's changed. But not that I miss everybody else, but so we'll watch that video, and it talks about the fact that because her pump, it was clogged. So she actually wasn't getting the insulin that she needed. So she ended up going into DKA. And so they figured it all out. So I personally think it's a really good video, and it's coming from an actual patient rather than an educational view. So we're doing one educational video and then one coming from a patient, which is of course why we're here, right? Patient teaching, taking care of people. So let's first pull up the our guide, which is going to be our PowerPoint. And let me just stretch it out here a little bit and move you guys. Okay, can you guys see this? At least one?
yes,
Yes.
Thank you.
yes, we can see PowerPoint.
Thank you. Okay, so we're gonna start just with the PowerPoint, do a few slides, and then I wanna watch the Khan Academy video because it goes over a little more of diabetes type 2. And I'll add in my stuff as well, but let's just get started at this point. Oops. Okay, so as I had mentioned, I only have 31 slides. You guys have like 70 something. That would be, I mean, personally, in my opinion, very repetitive. So I trimmed it down to make what I thought was important. So first and foremost, I think that we're all familiar that there are different types of diabetes. There's type 1, there's type 2, we have pre-diabetes, we have gestational diabetes. There's 2 other types that we'll talk about when we get there, and different ways that we treat diabetes, right? Depending on if you actually have the diagnosis or if you're pre-diabetic, if you're going to do insulin, if you're going to do medication, if you're going to just start off by maybe eating better, lowering carbs, whatever it is, exercise and whatnot. And we'll go through that as we go through the PowerPoint. So type 1 diabetes, as most of us know, is basically where you're not, you are dependent on insulin. We must have insulin. If we don't have the insulin, unfortunately, what's going to happen, we're just going to have all this glucose floating around in our vascular system, and it's not able to go into the cells where it can actually do what it needs to do. So can somebody just brief and just very, brief terms tell me, what do beta cells actually do?
They help secrete insulin.
Exactly. Perfect. So that's why it says here destruction of beta cells. So when we're dealing with somebody who is diagnosed with type 1 diabetes, and this is just an Amanda side note, and I think most of you would agree, when we're speaking with patients, this is just my thing. I prefer, and I do my very best, I'm not perfect, but I do my very best to say, oh, not that diabetic, the patient with diabetes, right? So that's just kind of a side note to kind of keep in mind. It's kind of like my population I work with. I don't like to say, oh, that addict over there, or it's kind of impersonal. It's a person who is struggling with addiction or whatnot. So same thing with people who have diabetes, right? It kind of, it's just, in my opinion, it's a little bit disrespectful, and we always want to put our best foot forward when we're speaking. And diabetes, a lot of it, in my opinion, is education, because what do I say every time? We want to prevent, and we know what we're preventing a lot with diabetes most of the time: DKA and wounds, right? Amputations, all of these awful things that we've seen and probably have dealt with our family members too. So type 1 diabetes, as now I just know your voices, that was Lizette. She had mentioned, so our beta cells are what produce insulin. So if we have a destruction of them, we are not having it. So we are insulin dependent. We must have insulin. Can insulin, and sorry, I have to, this is how I teach, and you have to unmute yourself to do it, but can you take insulin orally?
Yes.
No.
Correct. Exactly. Yes. So insulin, no. We'll talk about metformin, and there's other, medications that can help level out blood sugar. But just as a nice quick reminder, just in case you forgot, because if it's been a while and you haven't been around insulin or dealing with the diabetic population, we can give insulin. Mainly we give it sub-Q. We talk about that later. And we can also give it IV. Just as a side note, in case I forget to mention it, we have to be really careful. We never want to rush a patient in and, fill them up with insulin super, super fast, because everything is very, very slow, because we don't want to go way up or way down too fast. So we have to be really, really careful, especially if you end up working in the emergency room, or if you work anywhere you work. I mean, you could work in a clinic for ophthalmology and have a diabetic patient come in, or I just did exactly what I said not to do, but you know what I mean. They're not with the patient right now. So, and they could be showing signs and symptoms of something, and then I can catch that and prevent potential complications or hospitalizations or potentially DKA, which is a big, 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 big deal. Okay. So we went over the most important part. Basically, we already know this, that type 1 diabetes, we definitely need insulin, and we can do that in a couple of different ways that we'll talk about. One being giving yourself your own injections. There's certain sliding scales. There's certain, sometimes just scheduled. Some people will actually just, and I actually have one patient at the forum, they allow him to do this, is they will let him say at some point, I need this much insulin. And if they feel comfortable with it, they'll just give that amount. I don't know how I feel about that, but so far he's still doing well, and he's cognitively intact, and that's one of the biggest, well, he doesn't have dementia either, but he's doing well, so I guess it's working. So I don't we don't take that patient. So if you are with me, we don't take that patient, just because I'm not quite comfortable with it. Then we have type 2. So type 2 is a little bit, in my opinion, a little bit more complex, because we used to, I mean, it's obviously becoming, does it say epidemic on here? It should. It's becoming much, much, much more common. And it used to be called the adult onset, right? Because it would happen later in life. Unfortunately, a lot, in 95% of the cases that are being diagnosed are type 2. And it's unfortunate because, and I think it says it on the other one, but I do want to point out, largest risk factor is obesity. And, just the way the world is right now, right? The economy, people are working so hard that it's really hard to find the time and money to be able to buy food that's healthy and what's cheaper. McDonald's or whatever, or food that maybe not as healthy. And so obesity, as we all know, is on the rise. And being really sensitive, please, also when we're doing the patient teaching. And as I watch the videos, and this is not critiquing anybody, because so far so good, is being really careful with our words. We want to be really sensitive, right? I mean, it doesn't feel good to go to any doctor. I mean, walk into your gynecologist, and what do they do? I mean, any doctor, you get weighed, you do all that, and then what is usually the talk? Oh, you know, it looks like your BMI, this, that, the other, and just choosing our words wisely so that we don't unintentionally shame somebody. Because once we do that, psychologically, I mean, imagine yourself, wouldn't you kind of shut down a little bit, like, oh, like, okay, and it kind of makes you feel not good about yourself. And that doesn't mean that we're not giving the truth, but it's all about the verbiage. And that's why I had you make that video, by the way. I really wanted you to practice like using, and again, no one's perfect. We all have our days where we're a little bit off, but using the correct verbiage. So obesity, of course, is a huge factor. And then having to talk to them about changing that and exercising and all of this stuff that people don't want to do. And it's hard. It's hard. It's hard to change your lifestyle. If I told you right now, I'm going to cut half of your calories, and even if you don't need to, and do this huge different lifestyle and add on to your school that you're doing, you have to walk an hour a day, and then you have to do this, all of these things, not smoke as much, and do all of these changes. It's really difficult. So really just having that therapeutic communication and that understanding of what your patient's going through, I think is really important. And I think you all agree with that. But sometimes that can get forgotten, and just keeping that in the forefront of your mind. So as I had mentioned earlier, so the children now, so, oh, good, it does say epidemic. So we have the epidemic. It's becoming more and more common that children or teens are getting diagnosed due to usually obesity, and genetics, of course, plays a part in this as well. But that's why we don't call it adult onset diabetes anymore, because we're seeing it so often in children. And I mean, imagine trying to, I've been a part of it. I've never actually been the nurse doing it, but in nursing school, I had to, or not had to, I was a part of, it was part of clinical, and it was a good experience. But watching somebody have to like teach a 12-year-old about insulin, and having, you know, of course they tried other things first, because insulin is not always the first thing with diabetes type 2, right? Because usually your body's not completely shut off, it's more resistance. So it kind of depends. So usually what we want to do is, okay, lose some weight, maybe start a medication like metformin, which we'll talk about, keep a close eye, and do things like that rather than just go straight to insulin, right? But for this particular child that I was dealing with, excuse me, if I were in public, everyone would be looking at me. Do we all get that COVID stare? Or is it just me? I don't know. So yeah, we had to teach injections, and it's something that we don't want to do. So if we can avoid it, and as parents too, if we start to see that, and I mean, or if you're taking your, someone brought in their child and you noticed, even if they're coming in for something else, maybe having a conversation again therapeutically about, you know, their child and the risk and what that could mean. Because a lot of the times if we hear things like, you know, I'm not saying jump right to amputation, but if we hear the potential consequences of diabetes, because just because we know about it doesn't mean that they know what's actually happening in the body. They just may think, oh, you just take this medicine and life is fine, when we all know that that's not really what is happening. So, okay, so as I mentioned earlier, we have the type 1, type 2, pre-diabetic, of course, gestational when women are pregnant. And then we mentioned pre-diabetes as well. And that's usually has more to do with, hopefully lifestyle changes can change it around, and we could get kind of back on track, and then just be aware that we may be more susceptible for many different reasons, either being overweight, genetics, what have you. And then there can be secondary diabetes. And I think this is really interesting. And this is kind of one of those things that I think is not talked about, or I've never heard any. I don't even, I mean, it's been a long time, but I don't remember this being a big part of the lecture. And it has something interesting. So your pancreas obviously is what we're talking about, right? I didn't even mention that, but I think we all knew that's the gland. And then insulin would be the hormone, right? And insulin allows glucose to go into the cell, as we mentioned earlier. So your pancreas obviously is extremely important. It does many, many things, but there's certain things to think about. Number one, drugs. It could be medication, but of course I'm going to talk about this because this is my favorite thing, but well, it's not my favorite thing, but to teach about is addiction. A lot of people don't realize, I mean, imagine somebody that overuses alcohol. How much sugar is in alcohol? It's a lot of sugar. And so if somebody's been drinking, I don't know, a pint of alcohol every single day for 15 years, that's probably going to take a hit on your pancreas, right? Your pancreas is on overdrive. It's basically like eating a bunch of candy every single day. So that's something to consider. And I have a lot of my patients, they're pre-diabetic or potentially diabetic because of that. Or some sort of trauma might happen to your pancreas. So if you were in an accident and maybe you lost some of your pancreas, you might not have enough beta cells to do what needs to be done. And so that can happen. So I wanted to mention that this is something that I think a lot of us don't think about, but this is something that can happen as well. Just kind of a fun fact, I guess. It's fun for me. Okay, so before we start here, so it's 8:27. My estimation, sorry, I usually tell you guys when I think we're going to be done. So last time we had class, because there was a holiday, we actually went over. Today, we're definitely going to be under just because of what I mentioned earlier about the kind of, this is a lot of review. So I'm going to stop at this point and we're going to watch the Khan Academy video. It's 8 minutes. I like it because it talks about diabetes type 2 mainly, and it kind of helps introduce some things that I want to focus on as well. So before we start that video, does anybody have anything that they want to say, a comment, any patient interactions they've had, or some story or question?
I actually, which is funny, for pediatrics, we had to do articles and look up research articles.
Mm-hmm.
And so my article this week was actually on obesity and diabetes in children. And they did a bunch of exercise tests with the children, and they found out that because they got type 2 diabetes at a young age and were obese at a young age, they had more cardiovascular issues when they were adults. And so they were like saying, especially in Hispanic children, that it's prevalent, so that they need to start teaching about health at a younger age.
Perfect. And that was Miss Carol's class, right? I think she told me that.
Yeah, Miss Carol's class.
That you guys were doing. Okay, yeah, you have to do like 3 journals or something. So awesome. And you bring up a great point about different, cultures and diet and all of these things that are just, it's not good, it's not bad. I mean, but it's all in moderation as well. And of course, I mean, for myself, when people come to my house, what do I want to do? I want to feed them, right? So we have to think about that. And thank you. That's an excellent example. And send me that article if you have it, just because I want to see it, if you remember. I know you just got off work, so you're going to go to sleep, but after that, when you wake up, but it's true. It is a lot more children. And I think that prevention is key. And if we can get them while they're young, it's like me wanting to put in addiction education as part of the curriculum from like 6th grade to graduation of high school. I mean, do we really need to know geometry? Has anyone ever used geometry after high school? I don't know. Just, that's probably going to be my thesis. Anyway, perfect. Thank you for sharing that. Does anyone else have anything else that they want to share, questions or comments before we start the kind of an overview of type 2? And I think it introduces DKA, which is the reason I chose it. Okay, so we'll go ahead and start that. I'm just so that you can plan your life, because I know you have class. I think I have a chat. Sorry, let me just, okay. So, oh, I'll put that down there so you can see, so that you can kind of plan your morning. So I'm kind of estimating, so we can do one of a couple things, depending on how this goes. And if people have questions, of course, we'll take a break. If not, I mean, I'm looking at my notes. I'm kind of anticipating us being done no later than 9:30, unless, and I'm fine to go till 10:10. It's just, again, I don't want to, I want the quality. I want you to get the most you can, rather than learning the same thing over and over and over and over and over again. Like, we'll do a little bit of insulin stuff that you may have forgotten about. I feel like we talked about it in another, I don't know. I teach so many different places. I don't know what I've taught. So, but just little reminders here and there. So we'll watch this video together, because I believe it's a nice introduction to what we're going to talk about. And then we'll review DKA for sure, which has to do with ketosis. They kind of go together. What is before we start, could someone just explain very simply what the word ketosis means, if you know it?
Is that like a buildup of ketones in the blood? So
And-
it kind of makes the blood acidic?
Yes. It's like, I'm like, are you reading it? It's exactly how it says it in the book. Yes, no, it's perfect. Exactly. That's exactly right, Lizette. So when your body isn't able to, as we had mentioned earlier, isn't able to intake, if we don't have enough insulin, we don't have the sugar going into the cells, our body's going to go into deprivation, right? So it's going to need to do my favorite word, homeostasis, and it's going to need to do something. So what does it start to burn? It starts to burn fat, right? And then so if you know what ketones means, and then you are absolutely correct, it creates an acidity in your blood. And that's why people get that, what's it called? Kussmaul's breathing, where it's a very labored breathing, which we'll talk about later. It's in the slides going on. And that fruity breath, right? Because there's so much sugar. So one thing before I forget, and then I will start the video, is when I was in nursing school, well, I still am, but when I was in your program, one thing, I don't know why it just stuck with me, is somebody explained diabetes, and it helped me so much to understand the whole process. Like, well, why amputations, and why this and why that, and why retinopathy, and why kidney damage, and thinking about the blood almost, and I'm sure most of you probably already think of it this way, but if you don't, I mean, it really helped me to this day. It's almost like syrup, right? If your blood sugar is not, I mean, the whole goal of any disease, disorder, what have you, is to manage it well, right? So if we're not managing it well, and again, we don't want to shame anybody, we want to teach. So hopefully we're preventing things, maybe scare them a little bit, but nicely, because that usually helps people. If I'm afraid that I'm going to lose my foot, I don't want to lose my foot. Who wants to lose their foot? So that's why we do teaching on that, which we will definitely talk about. But I think of it like that. And if you have kind of syrupy blood, what does blood do? Well, it does many things, but oxygen, right? So, and it's hurting your vascular system. So it's hurting your vascular system, as Kalisha mentioned. So that can have a lot to do with potential cardiovascular problems. That's on the macro level. And then we have the micro level, which has to do more with like your eyes and your kidneys, and circulation down. Usually that's why a lot of the amputations tend to be on your lower extremities, is because that syrupy blood, it's really hard to get it to circulate, and we're losing oxygen, and we need that oxygen, right? And that's why if we do get a wound, why it's so important to not wait. And that's, I will never, I'm sorry, I know I do this, we will be done, but I will, there are those certain cases you will never ever forget. And I will never ever forget being at VMC, and we actually got to go to the hospital at that point, and it was heartbreaking. There was a patient there, middle-aged, I want to say. It was a long time ago, but he obviously didn't want to lose his foot, and they were trying to figure out, okay, maybe we can just take off some of your toe. I mean, losing any body part, I mean, for myself, I mean, it would be devastating. I don't care if it's my pinky, the tip of my pinky. I don't care what for me personally, we all have our our thing, and nobody wants to lose a limb. I mean, especially if we were born fully with all our limbs and everything, and all of a sudden now you made a mistake. He went to the beach, cut his foot. I don't even know what it was, probably something small. I mean, and a lot of the time we don't feel it when we have neuropathy, which we'll talk about as well. And what did he do? What most of us do. I'm one of the biggest key players. I won't go to the doctor unless I'm like, feel like I'm gonna die. Or I'm vomiting blood profusely. But other than that, I mean, what did he do? He didn't go. And if he would have went, he ended up actually losing his entire foot. And he was just, how am I going to work? It affects everything. Biopsychosocial, right? Everything. And it was really hard to watch and be a part of, especially I was a baby nurse. I mean, I think I was like first semester, and it was, you know me, I'm sensitive. I went to the bathroom and did my own crying and dealt with it in my own way. But there's a lot of regret when things like that happen, because it's like, if I would have came in, this wouldn't be happening. So if we can teach beforehand, hopefully, and really, really teach, not just teach because we have to, really sit with the patient and have them understand, hopefully we can prevent that. So anyhow, okay, look, we'll start the video. I did that for you, Denise. I know you like the stories.
Thank you.
You're welcome. I think they help to connect, and I personally believe it really shows that you, like, if I can, I remember this how many years later, and how much it affects you. Okay, so this is the Khan Academy video I'm going to share with you. Maybe. I'm sorry, I have so many windows open because I don't want to lose anything. Can you guys see that? Did I share it? This is Khan Academy.
Yes.
Okay. Okay, so this is 7 minutes. And then it basically slides us right into where we are on our slides. And then we'll see where we are. Okay.
Diabetes mellitus is a group of disorders that's caused by improper function of insulin, which is a hormone produced by the pancreas. And insulin is responsible for helping regulate blood sugar or glucose levels in the blood. Now, since it's a group of diseases, there are actually multiple different underlying causes of diabetes mellitus. And one of these causes is known as type 2 diabetes. Now, before we dive into the actual cause of type 2 diabetes, let's first get a better understanding of how exactly insulin works. And there are two major steps. So imagine that you just ate a big meal, maybe like a bowl of pasta or something, and your body is currently absorbing all of those nutrients from your digestive system into your bloodstream. Now, one of these nutrients is glucose. And as your body absorbs it, that glucose starts building up in the bloodstream. And in this feeding or absorptive state, your body wants to store this glucose in places like the liver and muscle cells so that it can be used for energy later when the body needs it. But unfortunately, glucose on its own can't get into these cells. In a sense, these cells are locked. But fortunately, the pancreas is able to help with this problem. So there are a couple of types of cells in the pancreas that sense blood sugar levels. And these cells are located in the islets of Langerhans. And these green cells here in the islets of Langerhans are meant to represent the beta cells. And when the blood glucose increases, the beta cells of the pancreas sense this change, and they secrete a hormone known as insulin into the blood. And what insulin does is it acts like a key that can unlock these cells so that the glucose can be stored in both the liver and the muscle cells. So you can see that there are two steps in order for insulin to function properly. And the first is that these beta cells of the endocrine portion of the pancreas have to be functioning in order to secrete the insulin into the blood. And then second, these cells have to respond to the insulin in order to unlock them so that the glucose can be taken out of the blood to decrease the blood glucose levels. Now, diabetes mellitus can be caused by dysfunction at either of these two steps. So if the beta cells aren't functioning properly or they're being destroyed, as in type 1 diabetes, there isn't enough insulin to be produced to unlock the cells. And what happens is that the glucose builds up in the bloodstream, and that person will develop diabetes mellitus. However, similarly, in step 2, if the cells aren't properly responding to the insulin in the blood, then they can't be unlocked and the glucose will build up in the blood vessels and you'll get hyperglycemia and the person will develop diabetes mellitus. So this is what I meant earlier when I said that diabetes is a group of disorders, because multiple different mechanisms can result in diabetes mellitus. So in general, type 2 diabetes is caused by dysfunction of this second step. And this is known as insulin resistance. So in type 2 diabetes, the beta cells of the pancreas are functioning properly and they're able to produce insulin, but that insulin isn't able to have its proper effect on the cells throughout the body. However, it is important to note that as the disease does progress, the pancreas can become effective and eventually decrease its insulin production. But in general, type 2 diabetes is thought of as primarily due to this insulin resistance. So what exactly causes the cells to become resistant to insulin? Well, unfortunately, there's no simple answer to this, and the cause of type 2 diabetes is very complex and includes many different factors that work together to cause the problem. So let's get a little bit better idea of this. So I'm going to just erase some of our work here so we can get a little more room. So what are some of these risk factors? Well, one of the most important ones is actually genetics. In fact, having a family history, say in someone's parents or grandparents, of type 2 diabetes is one of the biggest risk factors for developing type 2 diabetes. Other factors include obesity, hypertension, and increasing age. And it's the interaction of all these different factors plus more that end up resulting in insulin resistance. But how can we maybe understand this a little bit better? Well, one of the factors that we understand maybe a little bit better than some of the others is the effect of obesity. So let's bring back that lock I described earlier. So if you think of obesity as kind of this perpetual feeding state, or in a sense that the body is continuously being exposed to insulin released by the pancreas in an effort to bring down the increased glucose from this perpetual feeding state, over time, the receptors on the cells, or these locks, become desensitized to the insulin, and they become resistant to its effect. So let's use an analogy to help understand this idea of resistance. So instead of a lock, pretend this is a person, and this person decides to put on a baseball cap. So when you first put on a baseball cap, you can feel it on your head. However, over time, say 10, 15 minutes, this constant stimulation of the touch receptors results in a desensitization to the feeling of the ball cap on your head. And it feels like it's no longer there. So this is kind of similar to the cells in the body. If they're constantly exposed to this insulin, they'll stop responding to it and the cell won't become unlocked. Now, initially, the pancreas is able to compensate for this resistance by producing more insulin. However, eventually, as time progresses, the pancreas cannot keep up to overcome the insulin resistance, and eventually the body will lose its ability to lower the blood glucose level with insulin, and this will result in hyperglycemia and the complications that are associated with it. But this process can take time. In fact, from the time this insulin resistance starts to when someone would develop symptoms of type 2 diabetes can actually take multiple years. But at the same time, early diagnosis and treatment is critical to prevent the serious complications associated with diabetes. And for this reason, It's very important to screen people who are at risk, people who have some of these risk factors. It's important to screen them for type 2 diabetes. So they should regularly have their blood glucose levels monitored for hyperglycemia so that it can be detected and treatment can be started even before he or she will develop symptoms. So I hope this gives you a better understanding of what causes type 2 diabetes. It's not caused by a problem with the pancreas itself and the ability to produce insulin. Instead, it's caused by this insulin resistance by the cells throughout the body that are supposed to respond to insulin.
Go away. Okay. Perfect. Okay. You guys can hear me?
Yes.
Thank you.
Yes.
Okay. So as I had mentioned earlier, that hopefully once I showed the video, it kind of would resonate why I was showing it. I think it's first and foremost, that voice is so, now I'm like, it made me a little tired. So soothing, very easy to understand. And just a really good reminder of kind of the differences, even though I know we know it. I love the drawings. I'm a huge advocate for Khan Academy. If you have kids, it's really great with math and everything, and nursing school as well. Just make sure that the reviews are good, and obviously that you have a somewhat understanding so that you know that you're not getting wrong information just in case. So the takeaway from that video and why I showed it, number one, was just kind of a nice friendly reminder, and so that you're not just listening to me talk the entire time. I think it breaks it up a little bit. The other thing, and I wrote it down so I wouldn't forget to say it, has to do with not forgetting that most of the time, that's why type 2 those who are suffering with type 2 diabetes don't, I hate saying the word don't usually, because I feel like so many of my patients are on insulin, but they don't start on insulin because they're still producing the insulin, right? So they just may not be getting enough inside the cells. So they're not feeling well, they feel lethargic. And one thing he mentioned at the end, which I really liked, was to keep in mind, a lot of the times people have, they're either pre-diabetic or potentially the patient is suffering with diabetes type 2 and doesn't even know it. And until it just becomes so bad that they end up going into the doctor or the emergency room, and then they're diagnosed, and then luckily can get on track. Because I don't know if any of you have ever, I mean, just having the flu, right? Doesn't feel good. We want our patients and just people in general just not to have to suffer with these secondary issues. So that's one thing. And then the second thing is, so usually when you're first diagnosed, like I had mentioned, you're not going to start with insulin. You're going to start with all that other stuff we talked about: exercise, diet, maybe metformin. And then potentially later on, the pancreas will become more damaged, but depending on the person, depending on genetics, depending on many different factors. And so insulin may need to be implemented. And it's just, again, another way to help so that the patient or client or what have you doesn't get more and more secondary issues. So hopefully that was a nice kind of overview and kind of reminder of the differences between the two, and why some people who have diabetes type 2 are on insulin and some are not. And usually it unfortunately does usually become progressive, because what happens as we get older, just kind of sometimes naturally, we tend to gain a little bit more, usually belly fat. We live in a very stressful world. And what happens, what we just learned, I mean, with the endocrine system in general, what happens when we get stressed? We get more cortisol, which gives us more what? Blood sugar. Our blood sugar rate goes up because your body's trying to give you more energy to do what you need to do because you're stressed. So all of these things are contributing to it. Any questions about the video?
No.
No? Okay. I thought it was just a nice, smooth, relaxing video. Let's go back to our PowerPoint. Oops. I almost signed out. Oh my gosh. That's what I'm famous for, I know. Okay. All right, so back to the PowerPoint. Okay. Perfect. Can you guys see that?
Yes.
Yes.
Yes. I wish you could tell me like can see, like, sorry, I just want to make sure I'm not talking to like nothing. Okay. So things that we already know about diabetes in general, some signs and symptoms, the 3 Ps, right? Polydipsia, urea, and aphasia. And I think everybody knows what that means, right? Dipsia means what?
Thirst.
Thirst, excessive thirst.
Exactly. And does anyone know why? Why does that happen? I'm always like, it's really important to understand why, because a patient may ask you, why do I feel more thirsty? What is your body trying to do?
It was saying that the glucose is building up in the body, and so the body's trying to flush it out in the urine. So you're getting dehydrated, so you want to drink more.
Exactly. That's Andra. Thank you. So exactly. And it's your body's way again of trying to maintain homeostasis and thin out that blood glucose as well as get it out of your body. So it's trying to do something good. Unfortunately, it's doesn't, because then we have our polyuria, we're going to the bathroom all the time, and then you feel more hungry too then, right? Because you're not getting the glucose in the cell, so you're naturally feeling like you need to take in more. So it's this unfortunate 3 Ps that are happening. Fatigue, definitely, obviously, because we're not getting what our body needs as far as glucose in the cells. And if you didn't know this, your brain mainly works off of glucose. That's like the main contributor of being able to function well. That's why when people have low blood sugar, like myself right now, I'm just started getting hungry, and I'm having, you'll notice sometimes people will start off really kind of in a better state of mind, have a better cognitive level, and then they'll kind of not do as well as their blood sugar starts to drop. That makes sense. And all of us have experienced that, I'm sure.
So it's like when you're studying too much, like when you're studying, you get so tired and hungry.
That could definitely be, well, that could be from many things. That could be from diversion of not wanting to study and be like, oh yeah, I'm hungry. And it could be a coping mechanism too, but it could absolutely be from not, if you, because I know myself, once I'll be making a lesson plan and be working from home, and I'm like, oh my God, it's 3 o'clock and I have not eaten all day. And I'm so into it, I'm shaking, and I'm definitely obviously hypoglycemic, right? So that can absolutely be a reason why. So that's why it's good to have little snacks here and there, maybe little sinful snacks and healthy snacks to keep us going so that we can keep studying. Definitely more infection prone. And we'll talk about that in just a few slides. The ketoacidosis and all of that stuff I want to hold off on, because there's an actual, I think it's like a couple slides down. That's when we'll talk about that. Watch the other video and pretty much wrap up, other than I have a few questions about insulin, and I want to talk just briefly about insulin pumps, because some of you may not be as familiar. And I was going to show a video, but I'm like, okay, this is way too many videos. And I will post these videos. No, I'll post them too, but they'll be on this, obviously this as well, because I'm recording. Okay, so diagnosis. I don't like slides like this just because it depends. It's kind of like blood pressure. If you go to the doctor and your blood pressure is 140/90, they're going to keep an eye on it, right? They're not going to automatically say, usually the first line medication is a diuretic, or they're not going to immediately do that, right? So we're going to watch, obviously. Maybe you were supposed to fast. You said you did, but you didn't because it wasn't 8 hours or whatever it may be. But I think the takeaway here is that knowing what a normal blood glucose should be, most of you should know. What would be like, let's say you were fasting and you went in to get your blood glucose taken, what would you hope to kind of expect from your patient?
Less than 70?
100?
Yeah,
Less than 100.
perfect.
100.
Exactly. About 70 to 100, right? Give or take. And then depending on the last time your patient ate, obviously is going to tell you, and that's why you always ask if you do blood glucose and they were not fasting. That's why I always say, when's the last time you ate and what did you eat? So I can kind of make a critical thinking decision on how that is. So it's watched. And of course, if my patient is overweight and things, I'm noticing already things that are happening. And that's why we're talking to our patient. Interviews, right? What is going on? Or I call it assessment. I think is more patient friendly. What's going on at home? How's your stress? Does diabetes run in the family? All of these questions. Patient teaching, saying, explaining, because if this came back, and I know as myself, I'd be very, very scared, and I would want the nurse again to be very calm, like I saw some of in your voices when you did your videos. And I'm not saying you have to don't be fake, but to not, obviously I'm not going to walk in there with this big smile on my face, my normal happy self. I'm going to go in a little bit more, take a deep breath, and I have to set the tone, because that's just being respectful with your patients and explaining, this is the result at this point. This is what our plan is going to be. And hopefully with the correct, hopefully, I'm not talking to the patient, but to you, hopefully the correct turnaround, if I can, we can have some change going on. It's kind of like hypertension, do this, do that, do whatnot. And then they come back, and then we do some more testing. Of course, if the blood glucose is like 400 or something like that, something else may be done, and they may actually go to a emergency room or whatnot, depending on if there's symptoms going on. A1C, love it. I think it's like one of the best inventions ever, because that gives you a much better, I almost wish they could do that for blood pressure. Something like that, or maybe one of you should patent that and get rich. But it's great, because then I can have an overall, we all know what it is, but an overall 3-month kind of view of what's actually going on, because we all have good days and bad days. Let's be real. Okay. Sometimes we eat worse, and we know we're going to go to the doctor, and maybe we're trying to cope with food. We're human, right? So the A1C definitely gives you a much better, honest of what's actually been going on for the last 3 months, which is great, because that's what we want. And nobody wants to admit that I overate, or I did this, or I did that, or it's like, how many cigarettes do you smoke a day? Do you really think anyone's telling you the truth? We minimize, because many people do minimize, because we may feel shameful. So especially about body shaming, that's a big thing in the world right now. Okay, so moving along here. Of course, we know about patient teaching and the moderate exercise, and the reason I kept the slide was about the metformin. So metformin, I'm going to say a little bit, and then I'm going to ask a question, is usually given either with 2 meals a day, or with some of our patients 3 meals a day. The most common dose that I see is 500 milligrams with my patients. And what do we give metformin to type 1 diabetics, or see, I just did what I said not to do. Those that have type 2 diabetes, or type 1?
Type 2.
Type 2.
Exactly. And I'll answer the question, because obviously you all know why. Because it's helping, hopefully, to get more of the sugar in the blood into the cell without giving an injection, right? Because we can hopefully do this orally, like we talked about earlier. We're trying to avoid having to give insulin to those who are suffering with type 2 diabetes. So metformin is a good, most of you have probably seen this, and really anywhere, clinics, skilled nursing, definitely. I see it all the time, and that makes sense, right? Because I work in addiction, and all of my patients at El Camino, I would say 90% of the time suffer with alcoholism. So that would make sense. Most of them are actually pre-diabetic, and some of them are itty bitty, tiny, petite little women. but they're still pre-diabetic because they take in so much sugar. So we can't always just judge, oh, just because you're not overweight doesn't mean that you can't get this. So we always want to have, use our critical thinking. I'm just checking the group chat to make sure everyone's okay. Oh, 3 new messages. Wow. You guys are so funny. Okay. So yeah, all of this we know, education is the biggest thing for me, education. The more that you can let the patient know in the easiest terms to understand, not that they're a child, but that they can understand and know their level of understanding. You may be talking to a nurse. Actually, I have a patient right now that is a nurse in my group, and I love it. Some people find it intimidating. I think it's so fun. Like, yay, like you're here, you can have, it's awesome. It makes it really different. And of course, keeping up with the monitoring and medication, asking questions, like, do you know, how are you feeling? Some people will do like a diabetic journal, especially in the beginning, like so that we can regulate the medication dosages. That's really important, right? And I want to know, how do you feel when you wake up? How do you feel during the day when you're at work? Are you tired? Do you feel nauseous? Like, what's going on, so that I can better give my superior, who can actually do the, change of prescription or dosages, the best information as possible. And, nutrition therapy and stuff. Usually now they have, and nurses of course can do it too, but they'll have diabetic educators, which I think is great. But of course, as nurses, we should have a pretty good general idea about diabetes, because it is one of those things. I always say, oh, you don't need to leave this class being an endocrinologist. There are certain disease processing, I can't say the word, sorry, processes, whatever, that are very, very common, like diabetes, that we should have a better understanding on, maybe, and like thyroid and things like that, other than like an ingrown toenail. Does that make sense? Like, yeah. So I think you know what I'm trying to say. Okay. Same thing, where the video already talked about all of this. We want to our hope is to keep things stable. We want our blood glucose to stay as stable as possible, because you're going to feel better and you're going to save your body. It's like having hypertension. You don't want, so with hypertension, you have that blood pounding on your vascular system, and it kind of makes your vessels where it's not there. I know Miss Emily probably just has a different way of teaching this, because she's the expert. But how I think of it is, we have our, vascular system, and it's being pounded with all of this, obviously that's why it's called high blood pressure, right? Because your blood is putting so much pressure on your vascular system, and we want our vascular system to be taut. I mean, not teaching, but like taut, like firm. We don't want it to be wiggly, right? Because if it's wiggly, it gives it more chance to potentially have a burst, an aneurysm, more problems. So we want to keep it as consistent as possible. However, obviously it adjusts based on what we're doing. So if I told Jessica do, 100 jumping jacks, and then I take her blood pressure, of course it's going to be elevated, because your body's adjusting, and that's totally fine for that amount of time. But if it's like that for years and years and years, then you're going to notice potential problems, obviously, with your blood pressure, and you can have a stroke. You can have, it's actually one of the number one reasons is because of high blood pressure. So that's why we want to keep everything in control, because the more we keep our blood glucose in control, the least likely you're going to have issues with your eyes and your kidneys and neuropathy and all of those things, which is coming up on the slides. Keeping in mind, and I think a lot of people forget this when they're doing their teaching, is that, is this what's, yeah, okay, exercise, yeah. So if you're going to exercise, and it's important to remember, and I think of this, yeah, there's a question I think on your test, if you haven't taken it yet, about this little boy playing soccer or something, I don't remember, but something like that, where you get to know your body too. But if you're going to exercise, you want to plan ahead, because you don't want to become hypoglycemic. And excuse me. and teaching your patients, you know, keep something with you just in case, like something does happen and your blood sugar drops really quickly. We all know the whole 4 ounces of orange juice and that, you know, all of those tricks that we've learned in our skill nursing, I'm sure. And we want to avoid this. This is very, very important. This is where I want to talk about DKA. So it's 9:05. We have about 35 minutes left. So we can take a 5-minute break. I mean, I don't know if anyone needs to like void or get a cup of coffee or something. I can't see you. Hold on. Yeah, I said void. P, polyuria. Okay, so do you guys have your raise your hand things? Raise your hand if you want a 5-minute break. And I don't know how to see it. Like, you'd think it would just like, oh, there, oh, the thumbs up. So thumbs up if you want a break. Okay. All right, so come back at 9:15 and then we'll be done by 9:45. See, I lied. Maybe a little shorter. So come back at 9:15. Good. Luis, are you okay? Okay, you're doing the, I'm gonna pass out on you. Okay, go enjoy your break. Okay, you guys back?
I am.
Okay.
Yes.
Look, I'm on time. Okay, so question before first and foremost, can you see the blonde young lady on the screen? Not me, but well, I'm not that,
Yes.
but her. Okay. So before we play her video, and this is I also do like personal stories, and so I thought that's why this would be perfect. Can someone tell me?
Super important. Tell Daddy I gotta do this. I gotta listen.
Andra.
Oh shoot.
No, I just love it because I know your voice.
Shoot. I thought I was.
It's okay. It's okay. You guys are allowed to have children and families. Thank you for being here. I can only imagine. Okay, so when somebody is suffering with DKA, are they suffering from low hypoglycemia or hyperglycemia?
Glycemia.
Hyper.
And is there anybody that can actually explain to me what DKA would mean? Like if someone just asked you as a family member, what is DKA?
There's a buildup of broken down fat that eventually ends up creating an acidic environment, so that could lead to further complications and
No, exactly. It's kind of like when you explained earlier about ketones, and so that's why we test for ketones in the urine and whatnot, to kind of be able to tell. And that's why those who have diabetes will usually have the strips at home so that they can test themselves to know, okay, this is what might be going on. I better go into the hospital, because as we mentioned, it can be life-threatening, right? We are having you'll see. So this is her experience. I find it quite, she should be a speaker. I find it very, I really enjoyed watching it. I watched it twice because I enjoyed it. Okay.
With a video that I honestly never expected that I would be making. Yesterday was January 12th, 2018, and I was in the hospital with DKA, which is diabetic ketoacidosis. I'm home now and I'm feeling a lot better. I really want to share my story with you guys so that you are aware of the symptoms of DKA. I've had type 1 diabetes for 15 years now, and I've never ever had DKA. It honestly snuck up on me out of nowhere. I was feeling fine. I wasn't sick. I didn't have the flu. My blood sugars honestly weren't that high, and boom, I was in DKA. It was an extremely scary day yesterday. It's such a serious thing to have happen to you, and I just really want to share my experience with you guys so that you know when you should go get help. So I will get to my story in just a second, but before we start, for those of you who don't know what DKA is, I will go over that really quickly. So DKA stands for diabetic ketoacidosis, and it is the most serious complication that you can deal with if you have diabetes. DKA can develop when you don't have enough insulin in your body, and this is why, unfortunately, a lot of newly diagnosed diabetics are in DKA. Now, since I'm not a medical doctor at all, I'm going to give you the Mayo Clinic breakdown of exactly what DKA is. Without insulin in our body, glucose cannot enter cells. If our body is lacking insulin, it will start breaking down fat for energy. And this is where ketones come into play. So our liver will release ketones when our body is in kind of a starvation mode and it is burning down fat for energy. And then the more and more of these ketones build up in our bloodstream, the more acidic our blood becomes, which is extremely dangerous and can also be fatal. So now on to the next question. Why does DKA happen in the first place? So a lot of people think that DKA happens to diabetics that are poorly controlled. And yes, this is true. Poor management of type 1 diabetes can definitely lead to DKA, but this is not the only reason. So if you have an infection or a virus, this can lead to ketone production. Lack of insulin is an obvious reason. So if there's something wrong with your insulin pump or your insulin pump site, this can also lead to ketones. Any sort of physical trauma or emotional trauma, like any sort of major stress on your body, and then certain drugs and medications can contribute to that as well. This is the most important thing about DKA, is knowing the symptoms. Beyond Type 1 is a Type 1 diabetes organization, and they actually have a DKA awareness campaign. So I'm going to be reading off symptoms from their website. I'm going to link their website down below because they have some awesome information on DKA awareness and also some great posters that you can print off to spread DKA awareness. So here are the symptoms of DKA that you guys should definitely be looking out for. So the early symptoms would be high levels of ketones in your urine. So if you have those urine test strips and you're testing your urine, if you have a high level, that could be an early symptom. High blood sugars are also early symptoms. Frequent urination and extreme thirst are also early symptoms. More extreme symptoms would be nausea, vomiting, blurry vision, confusion, shortness of breath, and then eventually this can also lead to being in a coma. Okay, so now that you know what DKA is, what causes it, and what the symptoms are, let's go on to my story. Thursday, January 11th, I went to bed with a blood sugar of 6.5, and this is a very good blood sugar to go to bed with. I've been feeling well all week, nothing wrong with me, no illnesses or viruses or anything like that, and I went to bed at 6.5, and I thought that's a really good blood sugar to go to bed with. So I fell asleep. I woke up in the middle of the night, just for no reason. Quite often when I wake up in the middle of the night, I will check my blood sugar. So I looked at my Libre and it said that I was 10 and stable. So I thought, oh, that's a bit strange. I went up a bit, but I don't know, it was nothing alarming. So I gave myself a correction with my insulin pump, then went back to sleep because Usually my corrections work. I woke up a few hours later and I was feeling like a little bit off, a little bit nauseous and like overheated. And I was like, that's weird. So I looked at my Libre again and I was around 13 millimoles per liter. And I thought, oh, that's really weird that I went up. But still, I wasn't that alarmed because 13 millimoles per liter is really not that high, not like anything to be alarmed about. So once again, I gave myself a correction and I've tried to go back to sleep. I didn't sleep for long though because I just kept feeling worse and worse. So I think my body woke me up again and I looked at my Libre and I was still 13. So it hadn't gone up anymore. I really wasn't that concerned because it was just stable at 13 for a couple hours. But I felt extremely nauseous. So I actually ended up going to the washroom and getting sick to my stomach. And then I also noticed that my vision was blurry and it was really scary. I just did not feel right at all. And I checked my blood sugar like manually with my glucometer and it matched my Libre. So I thought, I wonder if I have ketones because I know that these are symptoms of having high ketones in your blood. I have the urine strips for ketones. I didn't have the blood glucose monitor at that time. I obviously do now after this incident. I checked my urine and it was off the charts high ketone. The darkest the strip can get, that's what it was. And I was like, oh my God, that is not good. But I was a little bit confused because I always thought high ketones came with really high blood sugar, like high up in the 20s, but that obviously wasn't the case. I know you're all thinking, Michelle, change your insulin pump site. Don't worry, I was thinking the exact same thing. I was honestly physically too ill to do it. I was so sick. I could not physically change my insulin pump site. All I cared about was getting myself into the ER. So Rafi put me in the car and rushed me to the ER. I got in pretty much right away. They did the blood tests on me and it came back that I was in mild DKA. So luckily it was DKA caught pretty early, but still I did not feel well at all. Trust me, it was not a fun day. So they put me on an IV drip for a few hours. They did a lot of tests. They really didn't know what caused the DKA. So I was in for about 7 hours and at the end, my ketone levels had decreased quite a bit and they felt comfortable sending me home. The first thing I did was change my insulin pump site because in the back of my mind, I thought, I wonder if it's my insulin pump site causing this. So Rafi and I were changing my insulin pump site. I took my site out and I've never ever had this happen. It was gushing blood, like it was like a volcano. This most likely was the culprit. My insulin pump site was it had hit something or was in a pool of blood or something like that, but I feel like my body wasn't absorbing the insulin properly, which caused the buildup of ketones. Yet there still is the question of how come my blood sugar never went above 13 millimoles per liter? But the doctors told us that they have seen quite a few cases of DKA where blood sugars were not that elevated. So it's definitely a learning experience for me, and I really wanted to share my story with you guys so that you know that DKA can happen to anybody, and just overall be aware of the symptoms. That's all we can do.
Okay, so very well spoken, I think, and I love hearing from the actual patient's point of view. So a couple things before I forget it, and then of course if there's any questions. But one of the most important reasons I showed this video has to do with patient teaching, because just what this young woman had mentioned, her blood sugar was not that high. This can happen. We think of, you know, oh my gosh, it must be in the 600s or whatnot. So explaining to a patient, it could potentially, if you're having these symptoms, and they may have the strips at home or not, if you're having these symptoms, go into the hospital, because your blood sugar doesn't always need to be up at 600. Because who wants to go to the hospital? Nobody. And most of us are going to be in denial and wait until we could potentially be on the verge of a coma, as she had just mentioned, because that is kind of, unfortunately, if death were to happen, coma usually will come first. So that's really important for patient teaching, that you may be one of these people that it just happens. Number two, if it's happening and you have an insulin pump, and we'll just quickly talk about it now. Insulin pump, most of us know it, it's very convenient. How often do we normally change our insulin pump?
Like 2 to 3 days.
That exact. did you guys like actually like, you guys are so good. Yes, exactly. I really appreciate you. Everyone comes so prepared. So thank you. I wanted to give a little more appreciation. I know I said that last time, but I really appreciate that. Exactly. About every 2 to 3 days, that's when you'll change the insertion site. And basically it's not, I don't know if you've ever seen one. There's a picture, I think, I don't know if I erased it on here. I think it might be on here, but it's sub-Q. And you can adjust it yourself, as well as, you know, obviously it's there so that you don't have to stick yourself all the time. But is anybody aware what type of insulin is actually inside of the insulin pump?
Is it like
I have an insulin pump and I do Humalog.
Oh, wow. Okay. Thank you for, I had no idea. And thank you for sharing that. Wow. I should have you do this lecture or this part. You're all no, thank you. So it's rapid insulin. So at least from all my, I'm not an expert in diabetes, but from any research I have done and reading that I've done, it's always rapid acting. The last thing I want to say about the video, and then if there's any questions, is especially if you're doing, you guys didn't do really a lot of like real med surge, but that's why a lot of patients, when they're in the hospital, their insulin tends to go up because of the stress or if they have an infection. So just keeping that in mind, that might be why the levels are higher than they are. Like a patient might say, oh my God, my levels are never this high. What are you guys doing to me? Or, you know, something like that. You can explain, oh, when your body's under stress and you're in the hospital, you're not at home. That's obviously going to be stressful on for most people. For me, I would just be like, okay, a little bit of a.
I think Miss Ann explained it pretty well. She was saying that sometimes people come out of surgery and they've been NPO for like the whole time, and then they come out of surgery and they're like, their blood sugar's like off the charts.
Yeah.
And then it's kind of like, what the heck though? I haven't even eaten anything. Like, what's going on?
Yeah.
And she said it really well. She was saying basically like anytime you're stressed or the trauma or surgery, like you basically go into like a fight or flight mode, and then your liver will release all of that to try and like give you the energy you need during those times.
Exactly. Was that Andra?
Yeah.
Yeah. No. Is this Ann Cowles?
Yeah. It was pretty cool. It was really helpful.
She's just, oh, I'm going to miss her so much. She's never leaving. We already talked about that. She's there more than anyone else, and she's supposed to be retiring. So she can never leave. I think we should hold a protest without violence. So thank you. No, that was very well said. And well mentioned. Of course, we're NPO, right? So yeah, that's another reason. And patient teaching, explaining when to go to the hospital and all of that. I think she really explained it really well. And obviously you guys read because you answered all these questions correctly. But any questions from what she had to say? I mean, she had,
Miss Kit, I was gonna add some share an experience on the top of Andrea was saying. So I was so I had an insertion of an IUD, and it was like very painful. I haven't eaten for a while, like since breakfast, and then since I've been having pain so much, and I feel so stressed because of that pain, so I didn't eat anything. So, and then that night I went to the ER because it was so painful. I was feeling nausea and everything. So when I was at the ER, the doctor told me as well that I was pre-diabetic, and I was like, I haven't eaten anything, and then it was all because of that pain that once they inserted the IUD in me, so they decided to take it out.
So that's those stories actually completely are parallel because it has to do with fight or flight. Because obviously you didn't eat, so you should be hypo, but you're hyper because of your liver releasing, trying to create homeostasis. I was like, you guys planned that. That was perfect. Thank you. And that's important to know, right? Because these are things that I know that you all know, but it's not maybe right here. It's just kind of like floating in your head, but now this is why I wanted to do this lecture kind of as it's a lot of reminding, but there are those little things like what Andra and Jess just shared that remind us of these things that we may not have, maybe we didn't know, or maybe we've never seen it. Don't yawn, Luis. I'm just kidding. We yawn because we need oxygen, right? We're not breathing enough. Breathe. Okay, so we already know all about this. And basically this is what the whole video is about. We've talked about medication. Whoa. Getting a little excited here. We know about insulin, and we know that where we give it, we've already talked about that. We've talked about the insulin pump. Of course, there's teaching that goes along with that. There's several different types of insulin. There's rapid, short, intermediate, and long. What is the 24-hour insulin called?
Lantus.
Yes, good job. And can this insulin be mixed with any other insulin?
No.
No.
And if you mix, I know this is repetitive, but I'm doing it anyway. If you mix two insulins together that can be mixed together, let's say MPH and rapid, how long do you have before you can give that injection once it's mixed together in the same syringe?
15 minutes.
15 minutes, exactly. Otherwise, it could potentially bind to the MPH and change the amount of insulin that you're giving. So, very important. A lot of people don't know that. If you go, like, seriously, if you work at a skilled nursing facility, just for fun, go up to your boss. Actually, I'm picking on Luis because your face is the only one that I can see. Because I have like a skinny thing. Since your friend is my, or since your boss is one of my best friends, you should ask her and see if she knows the answer to that question. Because a lot of people don't know that. And it can potentially harm someone. You don't know. So, okay. So we already talked about the insulin pump. Hyperglycemia and hypoglycemia, I think, are pretty well known. Something that you might not know that's kind of a fun fact is that, and unfortunate, is that people sometimes when they get pulled over, they may be either or hypo or hyperglycemic, and whoever is pulling them over might think that they're drunk. Because especially if you're hyper, because you have that fruity breath. So what does that smell like? It smells like alcohol, right? So usually it's that, and they will actually have them do a breathalyzer and this whole thing. And also, just kind of a fun fact, if you want to know, or if you don't, you're here, you're gonna know, is if I know I have a patient who's diabetic that is coming in, or a patient with diabetes, sorry, I should practice what I preach. They may actually test positive for alcohol on their urine screen because they can pour sugars, right? And those sugars can ferment and it will be positive. But how do I know it's negative? If they don't have metabolites. So if they don't have metabolites, I know that they didn't drink alcohol because of their diabetes. Does that make sense? And how cool, I mean, it's such an interesting, they were actually kicking people out of the program prior because they didn't put two and two together because they didn't have a nurse. They just had, not just, but they had, what are those people? Therapists that were reading the test. Oh, it's positive, you know, whatever. They need a higher level of care, when really they were diabetic, spilling sugars, fermenting. But if you don't have a metabolite, then you obviously did not ingest something, right? Because you must metabolize it. Does that make sense? It's not going to be on a test or anything, but again, it's just that higher level of thinking. And I just thought it was really, really interesting. And then I got to do a whole little teaching on it, which was fun. So we know we went, pretty much went over all of this already. DKA, potential coma. I changed this a little bit on my own. That we already talked about the symptoms of hyperglycemia. Treatment, of course, we know what the treatment is of hyperglycemia, so we don't need to go over that. We talked about remembering about exercise and making sure that we have enough food in us in order to, you know, if we're going to exercise, because we don't want to drop too fast. So a lot of education and a lot of learning our bodies too. It takes some time. to adjust, of course, to any new diagnoses. Signs of hypoglycemia, we definitely probably, especially if you've been in a skilled nursing facility, have seen this as well. I mean, both of them you've seen. Hunger, because your body is in like, help me, deprivation, fight or flight, which Andra had mentioned, and Jessica. And we see all of these things, and irritability, confusion, and not to discount this, because we see this in a lot of our patients. And I know I keep mentioning skilled nursing, but that's just because that's what we're in right now. But we see a lot of this anyway, not disregarding it as, oh, they just have dementia. Maybe something's actually going on. So always following through and not being lazy, but not just, oh, they're fine. They may not be fine. Do they have diabetes? Yes. Maybe I should just do a finger stick to see what's going on, potentially. Let's assess more. Let's be thorough, because you can save somebody's life. I think this is all pretty self-explanatory. I'm trying to get to the wounds. That's why, because a lot of this you guys know. We always recheck blood sugar after, if someone is hypoglycemic, we give them something, we're going to recheck to make sure they're doing better. And usually they're going to start acting more normal, whatever normal is for them, depending on if they have any other comorbidities or other diagnoses. As we mentioned earlier, some things that can be fast sugars are the 4 ounces of orange juice. I don't know, Lifesavers seem to be, and I always remember life because it's life-saving, so Lifesavers, and it's actually one of the only candies that I like. But I'm not diabetic, but I still like them. And sometimes we'll have glucose tablets, things like that. And raisins, if you didn't know, are good to keep in there, and they're small, so you can keep it, easily in the car or wherever. Okay, so ketoacidosis we talked about. Lizette explained very, very well as to what this is. And we watched the video. Basically, your cells are starving, your fats are breaking down, we're becoming acidic. As she had mentioned, your blood basically is becoming acidic. And then as the nice young woman on the video, I don't know if she said her name, but you'll start to notice usually in the beginning those kind of like flu-like symptoms. I don't really feel good. You're going to have symptoms of hyperglycemia. Why? Because you have sugar just floating around, just all in your blood. If it's in your blood, it's not in your cells, right? And your body's using fat. We talked about the Kussmaul respirations that, and you're going to smell the fruity breath, which is also on your test if you haven't taken it yet. Just it says it right there anyway. So there you go. Fruity breath. Dehydration, which we talked about earlier, drinking more water, trying to thin it out, then you're peeing too much, potentially coma. And then unfortunately, people do die from this. And a lot of the time it's because treatment is given too late. And so we don't want to do that. Sorry, I got one chat. I just want to check to make sure that everyone's okay. Oh, you can't see my PowerPoint?
No.
I'm trying to say something. I'm sorry. Thank you. Now I just lost the thing, but thank you for letting me know. You guys, I need help. It's because I pressed a button over here, so stop share. Okay, now I can see all of you again. Oh my God, you're all still here. Thank you, Amy, for pointing that out. Now I can see. All right, so now let me share my screen and finish this up. Sorry about that. Hopefully you got, now can you see it?
Yes.
Sorry, during the last video I forgot, I just got excited and kept going. So
We didn't want to interrupt.
Thank you. Sorry, I know, because you can tell I get excited. So if there's any questions about anything that I did say, and you have this PowerPoint, let me know, of course, but I think the Kussmaul respirations and the fruity breath and everything, we've already covered this earlier on in the conversation. Sorry, I'm getting another chat, so I just want to make sure. Okay, yeah, agreed. most people thought I was still talking about the video, not the PowerPoint, which it kind of went together, sort of. So as the young woman had mentioned, when she went in, she was getting IV fluids, of course, due to dehydration, because she was probably voiding excessively, and she was vomiting and not doing well, and basically trying to get her back to feeling much, much better. They probably gave her some Zofran, who knows. Frequent glucose monitoring after is very important, and checking the electrolytes, potassium specifically, because as we all know, that has to do with our what's that thing called that beats our heart? So we want to make sure that our potassium is on point, and that we didn't lose too much through vomiting or excessive urination or whatnot. So as far as diabetic ketoacidosis, I think we've gone over it enough. We know how to check for it. We, good diabetes control, and we already talked about the long-term potential complications, the macro ones having to do with our vascular system that someone mentioned earlier. These two are the most common that I've seen, which have to do with the eyes and the kidneys, and then unfortunately kidney failure. And again, it's because that syrup, right? You're not getting enough blood, enough oxygen to this part of your body, and this is something that we want to avoid. We want our eyesight. We want to be able to not have to go to dialysis. We don't want this. So this is really important to let our patients know. Okay, so as we wrap up here, I have a question about neuropathy. So Lizette can't answer this, and Mel can't answer this. There's one other person that I can't remember. So, or Luis cannot answer this, because you guys have all answered questions for sure. And some other people, sorry, but for sure those three. So with neuropathy, first of all, what is neuropathy?
Bad circulation.
It's nerve damage.
Ending. Peripheral nerving.
Everything everyone just said is correct. Circulation issues, nerve pain, and why does this happen? Bad circulation, number one, is the reason. That's the main reason, and it has to do with that, like I keep saying, oh, syrupy blood, and things putting pressure on our nerves, and usually in the lower extremities, right? And what medication do we tend to always give? It's one of my favorites. We all know that. Gabapentin. I know that was my little Pedro. I heard your voice. We love gabapentin. And then what could be a danger to having neuropathy? Which I spelt wrong.
Well, lost your sensation, so you pretty much
injury.
Perfect.
Yes, you're reset for injury. Like for example, if there's like the stove is on and you could be burning and you don't have that sensation to sense it.
Exactly. And I spelled that wrong. Sorry. We did danger. Did I? Danger? Is that, I don't think I've ever spelled it before, but either way, exactly.
If you have a wound, you won't be feeling the wound as well.
Exactly. If I step on something, I may not feel it. And that's why they always say do foot checks. And I know it seems so repetitive, but doing these checks are really important, because if you don't feel it, and then again, you could all of a sudden it develops into like this ulcer, which I'm going to show you next, infection and potential amputations, because we're not feeling it. So we need we don't have as much sensation basically. And then we can get things that look like this. And that's not good, because are we going to heal as well? No. Why? Because we don't have the oxygenation is not getting to the wound as it would normally do. Therefore, it's not going to heal as well. It takes way longer and can potentially and very much unfortunately cause amputation, which is, we don't want that for many, many, many reasons. So foot care, we know this. We know this up, down, all around. Very, very important. All of this we know. I'm not even going to go over it. we already know that, well, Andra already, thank you. I love it. Already taught us about this, and Miss Ann as well. So just knowing, you know, patients undergoing surgery, their sliding scale, as I mentioned earlier, is usually going to change. And now we'll be able to understand, if you didn't understand why, you can now have a reason, stress, NPO, all of that, because it's good to have, oh, that's the last slide. It's good to have an answer for your patient so that they're not freaking out like, oh my God, I'm always so perfect and now I'm like double what I am. What's happening? And then they get anxious. And the more anxious they get, what's going to happen? The higher their glucose is going to go, right? Potentially. So my last question for you is, can somebody give me an example of a short acting insulin?
Novolog?
Novolog, yeah. That's rapid.
Oh, short acting, sorry.
You're good. I go. I know you know, Lizette. Do it.
Humulin.
Regular.
Humulin R. You're asking about the regular?
Yeah.
Humulin R.
Yeah. Always the R means, and that's how I always remember it. Rapid. I'm not going to tell you how I remember, but my last clinical group knows how I remember, but I'm not going to share it on video, how I remember it. But Humalog, Novolog, or Rapid, short. And this is the thing. I don't remember every single insulin in the world. I don't give insulin. I do it not in the clinical setting, but I mean, my thing is, if I can remember like one or two of each, I'm doing pretty good. Now, obviously, if you work and this is something you're doing all the time, that's going to be much more, you know, you're going to know much more about it. Just like I feel very, very confident with addiction and very, very confident in skilled nursing, because to me, they're very actually similar. So we all have our comfort, if you will. We already talked about Lantus. Intermediate, we all know is MPH, right? I mean, that's like the most, and is MPH clear or cloudy? I have to ask.
Cloudy.
Good job. Perfect. And then the other one, I'll know if you know it because it's on the test. And it basically just tells me, or tells you to describe how to draw it up. It's just a good reminder because you guys are going back to like real clinicals, which is really exciting. So that's really what I had prepared for you today. Just really a lot having to do with the empathy of having, you know, diabetes and education, filling in some of the gaps, and asking you guys some questions to make sure that, you know, and you guys are on it. So, sorry when well, not sorry, but we went over what I thought we were going to go over just because I was enjoying the conversation and I think that it was important. I will post this as well as the 2 videos separate if you just want to watch it or share it with somebody maybe that you think it could be helpful to. Again, I will be posting within between Tuesday and Thursday the new schedule for GI. And today is officially our last day of this endocrine system. And the test closes on the 18th. Please don't forget, if you haven't taken it, please take it. And there is a study guide as well. I will be in touch about ATI. And even though we're not allowed to see ATI, and this is being recorded, but if which I don't mind, I might have access to it because I work at several schools, so maybe I can open it. I have no idea. And if I can, I'm going to do a review, like video, and post it for you guys if I have access, just to help you out, because they're hard. And again, it'll be on a sliding scale. So, any questions before we close? So you guys are getting out 20 minutes early. You can hopefully get a little like nap in before you go to see Miss Carol. And thank you for coming. And you guys are so consistent, and thank you for participating and everything.
Thank you, Miss Amanda.
Please talk now.
Thank you, Miss Amanda.
Thank you so much. It was good seeing all of you. Text me if you need anything, and I will have everything posted, and I'll see you next Monday for GI. So look out for the schedule under syllabus, okay? All right. Thank you guys so much.
Thank you. How many chapters for GI?
How many what?
Chapters?
Honestly, I have not even looked at it.
That's okay. I take a look here. No worries.
Yeah, I know it's not huge. So
okay. Thank you. Have a good day.
Of course, you too. Bye, guys. Thank you so much. Bye.